for coming. Tonight we're gonna really do a sort of biological active compound 101. Talk about what types of proteins and receptors in the body these compounds are going to interact with. Talk a little bit about how we describe how the body reacts to drugs and how we compare different drugs. I'll get into a little bit of the molecular pharmacology of some widely known or common, I guess, recreational drugs. And time permitting, we'll talk a little bit about the role of researchers and scientists in public policy with respect to drug use. And one of the reasons that I'm interested in that is that I come from a pharmacy background, but I've never practiced in a pharmacy. I decided that I really wanted to do the science instead while I was getting my pharmacy degree at Saskatchewan. So I went to Purdue University and did a PhD in the molecular pharmacology department there, and then came back to Canada and did some postdoctoral research in the medical faculty in the Department of Physiology. And then started actually with the School of Pharmacy before it had actually started working with some people on designing the pharmacology content for the course curriculum, and then becoming a professor there in, this was April of 2008, a couple months after the school officially admitted its first class. And so that's where I currently am. I'm an assistant professor at the School of Pharmacy, and I teach pharmacology for all sorts of different topics. So I've also had some opportunities to talk about drugs with respect to public policy. First, I was a consultant with the Health Professions Regulatory Advisory Council in 2008 and into 2009. And what they were doing was reviewing all sorts of health professions like midwives, respiratory therapists, and podiatrists, and making recommendations to the government about which of these professions should be able to prescribe additional drugs for their patients, and which ones and which drugs shouldn't they be allowed to prescribe. So that was a really interesting thing, talking about who had the, how can we make health delivery cheaper and more effective? Because if you go to one of these practitioners, often they know what drug you need, you know what drug you need, but they can't prescribe it, so you still have to go to a physician to actually get them to write down the prescription. That was a really fascinating. Work, and Bill 179 was accepted in the provincial legislature a couple months later. And then regionally, I've been a member of the Waterloo Region Integrated Drug Task Force, or Drug Strategy Task Force. And I don't know if any of you are familiar with integrated drug strategies. We have time, we'll have a very open discussion about them at the end. But basically, they're a way for communities usually to put down statements about how they want to deal with primarily problematic drug and alcohol use in their community. And so this strategy has been going, this task force has been going for a little more than a year now, and we're really starting to ramp up, so you might start to hear about some things going on in the news with that, maybe in the late spring or summer, when we start to really have a lot of maybe publicity in the local news about the recommendations. So feel free to ask questions whenever you'd like. I'm going to go through some stuff quickly. I might skip a few things in the interest of time, but if you want me to slow down or go through something again, just let me know, and I'll be happy to do it. One of the things I want to talk about first is really basic, and that's what types of proteins and substances drugs are going to interact with in the body. Since they don't interact with anything in the body, we can ingest all sorts of potentially biologically active compounds. If they don't get absorbed into the body, they'll just get excreted somehow, and you won't notice that you even ingested them. So how do drugs get into the body, and then when they do, how do they interact with it? This is, I know it's a little small, but these are some of the main types of drug targets. These are all protein drug targets. Most, when you think of drugs, whether they're recreational or therapeutic, most drugs interact with G protein coupled receptors, and there'll be at the coffee forum, there'll be a little talk on the very specific structural activity of G protein coupled receptors. And these are receptors that are coupled to G proteins. That's what they're called, G protein coupled receptors. So these are the targets of things like opioids, like morphine, all the major neurotransmitters, or most of the major neurotransmitter systems like dopamine and serotonin, and adrenaline will activate G protein coupled receptors. Then there's ion channels. And ion channels are expressed usually in excitable cells. And what is an excitable cell? That's a cell that usually has some sort of membrane voltage across its cell membrane. So, and most of these, when we think of excitable cells, are nerve cells as well as muscle cells. So there's ion channels as a big drug target, enzymes as well, and transporters. And we'll go through a few specific examples. But there's also some really, really simple drug targets. And one of them is the hydrogen ion. So Tums, or sodium bicarbonate, their drug target when we take an antacid isn't in the body at all. It's a hydrogen ion in the stomach. So they can be very simple drug targets. Others can be very complex. This is a structure of an enzyme called Abelson tyrosine kinase. What you can see here is in green is where this enzyme inhibitor is sitting in the active site of this kinase. And one of the reasons that this drug's a bit famous, it's called imatinib mesylate, or BAC, and it was one of the first molecular targeted drugs in chemotherapy. So for a long time we didn't have a really great strategy to deal with cancer. Our strategy was, let's kill cells in the body and hope we kill the cancer cells a little bit faster than we kill the other cells. But because we are going to kill a lot of other cells, we'll end up with hair loss because our skin cells are rapidly dividing, and bleeding in the GI tract because our GI tract cells are rapidly dividing. And we're going to suppress bone marrow function, so bone marrow rapidly dividing. And this was a success story with cancer therapy because they found out that this enzyme was upregulated or turned on all the time in this specific cancer, and then they went in and specifically designed a molecule to target it. So that's why it was called one of the first molecular targeted drugs, anti-cancer drugs. These are the G protein coupled receptors I was telling you about, and they're the target of over half of commercially available drugs, and many psychoactive recreational drugs as well. And they're coupled to this trimeric G protein. It's called a G protein because it binds GTP, which is a molecule inside of all the cells in the body. And they all have the same structure. They all have this, they call it serpentine, because it winds, this is the cell membrane, this is outside the cell and inside the cell, and this will wind in and out 7 times. So the drug comes in and it sits on the top, and that causes these little sections that are inside the membrane to move around and adjust themselves, and that activates the G protein inside, and then you get all sorts of things happening. And so I'll show lots of these kind of figures, but they're really just to highlight all the stuff that goes on inside the cells after you activate them. Has anyone taken an alpha-1 receptor agonist today, or a drug that turns on alpha-1 receptors? You might speak. There's a good chance maybe someone has. These are the target of decongestants. So if you have a stuffed up nose, you have a lot of fluid coming to your nasal cavity, you can take an alpha-1 receptor agonist. An agonist means it'll activate the receptor. And then you'll actually get constriction of the blood vessels in the nasal cavity, and so you'll get less fluid flow to the nasal cavity, and you can relieve some of the congestion. So this is an example of a G protein coupled receptor, and it still has these 7, goes in and out of the membrane 7 times. And this is an example of a G protein drug target. A whole other group of drug targets are called receptor tyrosine kinases. So they're on the cell surface as well. That's the outside of the cell, and the inside of the cell is down here. So they bind an activator on the outside of the cell, and stuff goes on the inside of the cell. But they're a little bit different than G protein coupled receptors in that they're tyrosine kinases. And what tyrosine kinases are proteins that will take phosphate groups and put them on other proteins, specifically on the amino acid tyrosine. An example of a receptor tyrosine kinase, or a receptor with tyrosine kinase activity, is the insulin receptor. So if you administer insulin, or if you release insulin from your own pancreas, it'll go to all sorts of cells in your body and activate the insulin receptor. What is insulin? Does anyone know what insulin does in the body? What's its major effect?
Metabolize the intake of sugar?
Yeah, it'll tell cells to take in sugar. So if you're diabetic, one of the signs is you've got high blood sugar. Because if you're a type 1 diabetic, your pancreas has been basically destroyed, or certain cells in the pancreas have been destroyed, and you're not producing your own insulin. So without the insulin, these cells don't know to take up the blood sugar, and the blood sugar goes up. And so you go in for blood tests and you go, oh, you've got high blood sugar. So what all these arrows are basically showing is that you activate an insulin receptor and all this stuff happens, and the end result is you insert a transporter that brings glucose in from the blood into the cells. So if you have high blood sugar and you're a healthy patient or a healthy person, you release insulin, it activates these receptors, and then it allows the cells to take sugar from the blood or outside the cells to the inside of the cell. Ion channels, I put this one in here just because it's my favorite, because I study it in my lab. This is the NMDA receptor, and it's an example of an ion drug target, or an ion channel drug target. What are ion channels? Well, they're proteins that sit in the cell that allow various ions to come in or to come out. And in this case, when you activate the NMDA receptor with glutamate, it brings in calcium and sodium into the cell, and actually potassium goes back out. NMDA receptors are really important in stroke and schizophrenia. We won't really get into that today, but they're also the target of dissociative anesthetics like ketamine, which is a veterinary tranquilizer, but is also used recreationally as well. And it's called a dissociative anesthetic because it gives you a real experience of disconnect between your body and mind. So those aren't all the types of drug targets, but they're a sampling of the types of targets the drugs that we take into the body are going to interact with. Some of them aren't in the body at all. They might be hydrogen ions, they might be water, and some of them are integral membrane proteins inside cells or on the cell surface. So how do we describe how a drug is going to interact with a receptor or with a cell or with the body in general? Well, for most proteins and most receptor drug interactions, the drug will have some sort of affinity for the protein. If the drug doesn't have any affinity for the protein, it will just pass on by and won't do anything. So the drug will have some sort of attraction. It will fit into the protein and it will bind onto the protein. And we can describe, and this is, I'm not going to do a physical chemistry talk, because this is as much as I know, but it'll come onto the cell, and we can measure how fast it binds the receptor, and we can also measure how fast it comes off of the receptor.
Does it eat away at the, does it deteriorate some of the
receptors?
Yeah.
No, not in this context. If you activate a receptor for a long time, then you can actually start to reduce the numbers of receptors. And that actually we'll discuss later. It really underlies some of what we see when we observe tolerance to a drug. So one of the things that the body wants to do, and we'll go through an example of this, the body likes everything to stay the same. So your blood pressure is normal, the pH of your blood is 7.4, your heart rate is between 60 and 80, your rate of your metabolic rate is similar, your hormonal levels are always the same, or at least within a range. So the body's always trying to maintain that. It's how we work best, or at least how the body thinks we work best. And so when you throw drugs into the mix, you can often cause a lot of imbalances in those homeostatic or balanced systems. And we'll talk about some very specific examples in a few slides. This is called a dose-response curve, and this is a real hallmark of describing how drugs react with the body, or react with cells. So a dose-response curve involves a dose, so this is an increasing amount of a drug, and a response. And the response can be anything. It could be how much you